Oh, go ahead, ma'am.
Hi, hello everyone. This is Dr. Spandana from Oasis Fertility. Today, I would like to enlighten few points regarding PGTA. So, I'll be presenting in a PPT format, and any doubts, questions can be posted. So, what is PGTA? The name itself has its own explanation. So P is pre-implantation and GT is for genetic testing. Yes, it is a genetic testing. And A is aneuploidy. Aneuploidy is nothing but it indicates it is a terminology used for number of chromosomes. As humans, we all have 23 pairs of chromosomes that is called as euploid status, which is normal. But when there is any deviation in the number of chromosomes, then that is called an aneuploid state. It is just a scientific term used for the structure and number of chromosomes. So, can I have the slides? Yeah. So, what is the scientific definition? Next slide, please. So it is just a testing of the DNA from a blastocyst stage embryo. So can PGTA be offered for all the fertility treatments? No, because the embryo should be available for us to do the biopsy. So especially for couple who are undergoing IVF treatments, then the embryo will be available so we can do biopsies on that. That is the blastocyst stage of embryo, which is nothing but a day 5 embryo. Day 0 when the fertilization occurs, later the embryo progresses to day 5. So on day 5 and also on day 6, the PGTA can be done. So this is why the PGTA is done on the blastocyst stage embryo. So is PGTA indicated for every couple? Again, the answer is no. There are few certain indications for which the PGTA is advised. The first comes maternal age. As the age advances, the aneuploid rate, that is what I have explained regarding the number of chromosomes, the aneuploid rate increases and the euploidity status gradually decreases. See, from the time we are in our mother's womb, the oocytes are with us in females. So as we age, oocytes also age. So increase in maternal age leads to aneuploidity, and so it is to be tested. And such couple are to be offered PGTA. And also in couple who already had previous IVF failures and previous miscarriages, and also in cases of severe male infertility, like when the sperm count is less than 1 million, less than 5 million, even for such couple we do advise PGTA. And also in cases of unexplained infertility, and when the couple already had prior aneuploid embryos, and also to decrease the time interval of pregnancy. For example, if we take a scenario, we have 12 fertilized eggs, out of which we could form like 6 blastocysts. So without PGTA, if we keep transferring these blastocysts, few might end up into miscarriages and few might end up into anomalous babies or something. So better to avoid such situations, we usually advise PGTA so that the time interval, all these transferred blastocysts, which like every FET we transfer one blastocyst and it 3-4 transfers and then you end up in a successful pregnancy. So prior to that, if we do a PGTA and screen all these embryos and transfer the euploid embryo, all the time wasted can be saved. So that is another indication. Next slide. So, how is the procedure done? There are like many misconceptions around us that during the biopsy will the embryo get damaged, and how is the procedure done exactly should be known when you're undergoing that testing. So usually it is laser assisted hatching. We use a laser beam to make a hole in the zona pellucida, that is nothing but an outer coverage of the embryo, and then cells are retrieved and sent for testing, and the embryo will remain back in the laboratory frozen. So it should be done by an expert embryologist in a highly equipped laboratories with specialized instrumentation. Expertise is important. And also, when we think about the risk of damage, it is almost like less than 5% damage to the embryo. And also, it is like less than 1% risk of misdiagnosis. And less than 5% cases, we might end up having no result. Can I have the next slide? So also this procedure is done on the outer layer of the blastocyst, that is the trophectoderm, that is again the covering. And there is inner cell mass which is not to be disturbed, and also the laser light is adjusted, the power of the laser light is adjusted, and also the location of the biopsy is also adjusted accordingly not to cause any damage to the inner cell mass, which in future leads to embryo formation. So usually everyone has a doubt, like, how much part of the embryo is taken or how many cells are taken. We hardly take 5 to 10 trophectoderm cells, which is not causing any damage, which will not cause any damage to the embryo. So I would also like to play a video. Can you please play this video of the procedure? I just wanted to show how the procedure happens in the laboratory. If I could play this video. So I think the video is not going to play. The next doubt arises in interpretation of the results. See, as fertility specialists, we are aware of the results, how to analyze. But when you see the report, even you will be anxious. What is happening in this report? There's so many things indicated. So what exactly is this? This is the embryo number, and this is the grading of the embryos. So here comes the role of grading. What exactly is this grading? This 1 to 4 indicates the expansion grading of the blastocyst. And this A to D, the second line, indicates the grading of the inner cell mass, which leads to the embryo formation. And the second grading leads to the grading of the trophectoderm. So depending on the grade, also we advise for PGTA. Not on all embryos can PGTA be done. So they select the best grade 2 embryos. A, B are very good, and C is also acceptable, and D is not acceptable. So such embryos are usually selected for a PGTA testing. So this is the sample type. What sample have we sent for the testing? So as I previously mentioned, it is trophectoderm, the outer lining of an embryo. And how are the embryo results interpreted? As I previously mentioned, they can interpret as aneuploid or they can interpret as euploid. And there is other complex terminology which is complex euploid, aneuploid. And also, this is the day on which the biopsy was done, on which day of embryo the biopsy was done, day 5 and day 6. Okay. And this is the mitotic score value, and on which, depending on which, the implantation rates also can be assessed. So this is again another test result, which the same thing, like the sample type and what is, if it, here it is showing there's only one euploid out of all these embryos. See what would have been done, like, if the PGT wouldn't have been done previously, we must have been ended up in transferring all these embryos and wasting our time. So this now we have PGTA results in our hand, and this euploid embryo can be transferred. So, what are all the genetic errors that can occur, and what are all genetic errors can be tested in a PGTA? See, PGTA is basically the number of chromosomal analysis, and there are other two types, and that is PGTA, PGTM, and PGTSR. For single gene disorders, the monogenic M is monogenic, so PGTM can be advised. And when there are structural rearrangements, when the paternal chromosomal analysis is done, and when there is a particular structural rearrangements, then PGTSR can also be advised in such couple. So these are few chromosomal abnormalities, the pictorial representation, in which here this part of the chromosome is deleted. So this is deletion. And when there is duplication, doubling, this is duplication. And when when there is inversion, and also something like substitution, and also translocation. All these are the various chromosomal abnormalities. So coming to single gene disorders like sickle cell anemia, thalassemia, and also many muscular dystrophies. We would have earlier seen babies with, all the muscular atrophy. So that can also be diagnosed. And the major structural abnormalities like, in PGTA-A, we can detect Downs, that is trisomy 21, 18 and 13, which are the most common causes, like almost like 60 to 70% of the first trimester miscarriages can occur due to such chromosomal abnormalities. And these can be avoided by prior testing. So these are the three different types which I mentioned. One is PGTA-A and the other is PGTM for the monogenic, and SR is for structural rearrangements. So this is something complex. When you read the result, it says mosaic. So we have an idea about euploid status, that is normal, and aneuploid status, that is there is some abnormalities. What is this mosaicism? When the part of it is abnormal, when there is mixture of this aneuploid and euploid cells, in a simpler term to denote, it can be termed as mosaicism. This is just a pictorial representation. So what level of mosaicism can be accepted and can be denoted as a euploid embryo? So less than 20%, it can be called as a euploid embryo. So 20 to 80% when we see all the mosaicism, then it is euploid, aneuploid mosaics. And if it is more than 80%, then we detect it as aneuploid. So what is the problem with this mosaicism? This is where the false negative picture comes into play. When this is the picture, yes, it is euploid, it is straightforward. And this is a bad embryo, it is aneuploid, it is again straightforward. But what about this false negative? What are we missing? This is called inner cell mass, which forms into a baby. When the biopsy is done on this outer cell mass, that is the trophectoderm nerve, when we take a cell from this layer and send for testing, it comes as euploid. But then what is happening? Here the inner cell mass is showing an aneuploid status. So this is where the PGTA can go wrong. So this false negative can occur, but that is very less percentage. If it is a false positive, that means when the biopsy is taken in this zone, that is when the status is aneuploid, the outer layer, but the embryo inner cell mass is euploid. So this can happen, but it is a very rare thing, and we can't think about rarity and not get the test done. Because 98% the results are perfectly done and the biopsies are also perfectly done. So we can't waste our time on thinking about the false negative and false positive. But we should have this in mind that, it can happen because no test is 100% correct. So as parents, and we always think that entire embryo is screened and we get a healthy live birth. That is quite natural. But we are not screening the entire embryo. We are taking a part of it. So the errors should be accepted, which is less than 1%. So for PGTA testing, we need a highly equipped highly equipped labs and also very skilled embryologist and tied up with a very good lab for the results. So all these can be utilized to increase your success rate at Oasis because we have a highly equipped lab and highly skilled embryologists who perform the biopsy, and also we have high-end instrumentations used for this testing. So I think to get a increased success rate, better all the couples who are indicated should undergo PGTA testing instead of thinking about what about the result, and in case if, and also people will be thinking that in case what if we get a bad result in PGTA, please don't worry about it. There are very low mosaics also, and you can be taken to a genetic counselor and know the effects of what all happens, and if there are any correctable things can be corrected. So please don't worry about the negative result. And what if we don't do a PGTA and transfer the same embryo, which is an aneuploid status? Obviously, we will be ending up in a miscarriage. So that is not advisable. So that is one thing I would like to suggest to every one of you who want to undergo PGTA to increase your success rate can please approach us. So any questions? I'm ready to answer. So there is a time limit of 2 to 3 weeks. Once we send the sample, the biopsy sample to the testing center, it will take 2 to 3 weeks minimum for us to obtain the result. So there is a waiting time of 2 to 3 weeks for us to get the results. Yes, of course, the PGTA can reduce the miscarriage rate by detecting the abnormal embryos prior to transfer, and there is obviously decreased miscarriages. So, can PGTA detect Downs? Yes, it can detect Down syndrome, and also it can also detect trisomies 18 and also 13. Yes, this is another important point. PGTA can be done on frozen embryos. So once the embryos are frozen, later the couple gets one embryo transferred and the transfer fails. So the next option we would obviously advise for a re-PGTA on the frozen embryos to know the status of the embryos. So how is this rebiopsy done? Once the embryos are frozen, they're thawed back to their original position and the expansion should happen, and then the biopsy happens on this expanded blastocyst stage. So any more questions?